Hello, everybody, and welcome to this panel that we have today on perinatal mental health. And we all know that pregnancy and postpartum is one period in a woman's life when she's in contact with the healthcare system. We also know that mental health issues really surface during this period for a variety of reasons, most of them related to, vulnerability, to factors in the family, to whether a pregnancy is unwanted or not, to issues related to a woman's own prior experiences, her own relationships with her family, biological factors, nutritional factors, and the whole stress and the angst around whether she'll have a normal pregnancy, a normal delivery. So it's indeed a time of a lot of emotions. Traditionally people say, oh, it's one of the happiest moments of a woman's life. But I think those of us who are working in the field also know that in addition to being the happiest, it's also a time fraught with a lot of tensions and a lot of anxieties, not just for the woman, but for all the people around her. So I think in that context, perinatal mental health has great importance. And today we have a lovely panel of clinicians with great experience in the field, and we are going to field some of the questions from them and listen to what they have to say about the topic. And of course, we'll have some time for question and answers later. So just to sort of one-line introductions to all my panelists, I'm going to start and, if you can say hello. Ranga Rao, Dr. Ranga Rao is from London, and he is a perinatal psychiatrist and works in one of the most prestigious inpatient mother-baby units in London. And I'm really delighted to have him here, not only because he's also, an alumni of NIMHANS, and worked with me, but the fact that he works in one of the best centers in the world. And I'm sure he'll add a lot of value to the discussion. And then I'm going to go to Dr. Latha Venkatram. She's one of those obstetricians who's, I think, as astute as a psychiatrist in picking up mental health problems and referring them to mental health professionals. So she's one of those. If there was a specialty called psycho-obstetrics, she'll probably be one of those who will head the department. So thank you for being there.
Thank you for supporting us. Yeah.
Great pleasure to have Lakshmi. Lakshmi is very unique because she's a certified perinatal psychiatry expert now. So she's one of the few obstetricians in India who actually done a certificate course in perinatal mental health. And so again, a sort of upcoming group of obstetricians and gynecologists who are extremely interested in the area. And finally, my colleague Dr. Veena Satyanarayan, who's a clinical psychologist, has been working in the field of perinatal mental health for more than 10 years, does a lot of intensive therapy work with women who are pregnant and postpartum, and has particular interest in what we call attachment needs of mothers and babies and therapies related to that. And I'm sure we're going to listen to some of those areas. So having made those introductions, I'm going to start off with the obstetricians in the panel. I'm going to ask Latha Venkatram that, that as somebody who's, like I said, a very astute clinician, have found all kinds of mental health problems presenting to you as an obstetrician. Would you sort of give us a flavor of the kind of problems that you normally encounter? And if you can remember one sort of exemplary case in brief that you can tell us.
Yeah, sure. Thank you very much, Prabha, for this wonderful panel. As obstetricians, we see a lot of mental health issues of late, especially in the last few years. We have been seeing more and more of mental health issues in pregnant women and postpartum also. Anxiety, especially in COVID days, COVID phobia was really difficult. Thanks for opening up those 24/7 lines, Prabha. The credit goes to you because many women got a lot of solace. Yeah, so anxiety is one of the things that is on the increase. And so the stress can lead to whatever is physiological, such as pregnancy, into a pathological state. That is, they can have depression, or even we have seen postpartum psychosis, bipolar problems, and tocophobia is also becoming more common. So we see a range of mental health issues in our setup. And as you know, we have been working closely, and you are getting to see more referrals from us.
You sort of remember a case that, stands out and,
Yeah, sure. This lady was a primie. She was unusually quiet. She came to book with us around 10, 11 weeks. She was accompanied by her mother and mother-in-law, both actually. And then in this very second visit, I mean, she was unusually quiet, I thought, and mother was answering all the questions. I asked her about her husband. She didn't say very much. The mother-in-law did not want to say very much about her son. And when she came the next time, suddenly she became quite violent in the clinic. So towards her mother. So I asked her what was happening. I asked the lady herself. She said, my mother has not been giving me medications. I have been on medications. See, as a part of routine history taking, we have few questions related to mental health. But unfortunately, they hadn't revealed anything. Neither the girl revealed anything, neither the mother or mother-in-law. And then I asked her what was happening. And she said, look, my husband is incapable of looking after himself. And I am pregnant now. I don't know what to do. And she just sort of just went on and on and on. And then we referred her onto you, and she had a lot of sessions with you. And she was a lady who had bipolar disorder and who was hesitant to take medications. And then she had a normal delivery, and postpartum, she again had lots of issues. And the whole thing used to be colored by the mother and mother-in-law. The husband was a specially abled person with cerebral palsy. And they hadn't told the mother-in-law that this girl has this problem. And it was such chaos, and they found it very, very difficult to accept. The families found it very, very difficult to accept such a thing. But anyway, and then funnily, after this pregnancy, within a year, in spite of contraceptive advice, she fell pregnant again. And then I said, look, the couple is unable to cope with the one child. And how can we just ask them to just get on with the second pregnancy? And I offered termination. You won't believe, Prabha, the mother and mother-in-law, they didn't want this pregnancy to be terminated. She said, she is going to produce the child. We are going to look after her. How could you say that you suggest termination?
Yeah, so, I understand, Latha. I think, it is quite challenging when, you have multiple issues.
Absolutely.
And one of the things, like you have mentioned, is it's not just working with the mother, but also working with the family.
Yes.
Lakshmi, would you be able to sort of mention the kind of problems that you have been encountering and any case which stands out in your mind?
If we were going to give a single terminology to say the most common type of things we face, it tends to be anxiety, because I think even before we became very mental health aware, looking back at our notes, the words we used to often write is patient anxious, mother anxious. So I think anxiety is what we see a fair amount. However, altered body language is maybe more common than anxiety, because there is something that is not quite right when we're doing the consultation, but we're not able to put our fingers at what it is. And we quite often call that as anxiety also. And we only understand what this is about as the pregnancy progresses and we get more details from the patient. One other observation we have started doing recently when we're looking back at the vital parameters that we do for all the patients in the antenatal visit is a lot of them are having a heart rate of around 95, 100, 105. But that is actually not their heart rate. I think coming into the hospital may be creating an artificial increase, or it may be the background of everything. So I think these are things which we are needing to keep an eye on as obstetricians. When you are mentioning about a case, one particular case that stands out, and that is something that happened recently, was a pregnant lady who booked with us during the COVID time. And so she did a video consultation booking, and it seemed like an uneventful low-risk pregnancy. So we had asked her to come for her 12-week visit. And only at that visit, we actually realized she has herself had a coarctation of aorta, for which she's had an open surgery. So there was something that stopped her from divulging that during the video consultation. Subsequently, things appeared to be going well, and she appeared to be coping well. And because of COVID and not allowing attenders inside, we had not realized that certain things were happening until she stopped attending couple of her routine visits. And then when we were inquiring what had happened, She herself was very forthcoming and mentioned her very good friend had committed suicide. And that had happened because of interpersonal issues between husband and wife. And she went at length to describe that whole episode and how she was the only friend whom she knew, and she feels that she was not able to help her. And when we discussed about would she like anything further to help her through this process, she said she's managing well. However, 2 weeks later, her mother insisted she wants to talk to me. And only then we realized that is in front of the daughter herself, she brought out the history that actually this couple also have fallen apart very early in pregnancy. This girl has faced domestic violence, and actually at around 10 weeks, she has left the house at midnight and has come to her mother's doorstep and is now living with her mother. So I think even with rapport building, there is still a lot of lacuna in what we understand as their health needs. And I think that was an eye-opener to me to say, even a seemingly well person, I think the search for what is actually, happening in the background is very, very important. She's currently ongoing, but she seems to say she's managing well. So we are keeping an eye on her as an obstetrician team alone. But I think surely more is required of it.
Thank you, Lakshmi, for that. I think you raised some... Sorry, go ahead, Latha. Go ahead.
It's okay, Prabha. Eliciting mental health issues is a very, very difficult thing as obstetrician. Even if you hit a rapport, as Lakshmi said, it's very difficult. Even if you gave a questionnaire, truth might not be revealed. That is the biggest problem. So we have to be clever at smelling mental health issues.
I think that's so important, Latha and Lakshmi. You raised some very important issues. One is, of course, the possible risk factors, which include a past history of a mental health problem, domestic violence, a life event during the pregnancy. So these are some things that you have raised, which are actually known to be predictors and risk factors for perinatal mental health problems. And of course, the whole issue of stigma, which we will come to later, because it's not easy to talk about mental health and how we need to be, unlike other conditions which may be revealed, mental health problems are something that people may not be forthcoming. And the whole cultural issue in our country of secrecy, of, not revealing certain kinds of information is another challenge that obstetricians face. I'm going to move on to Dr. Ranga now and sort of ask him, you've listened to both the obstetricians discussing some of these mental health issues, and particularly want to ask you about postpartum depression and also depression in pregnancy. And what do you think, why do you think it's important to address this issue, first of all? And what are the kinds of symptoms that women may present with to a midwife, to a nurse, to an obstetrician, which will make you suspect that this woman has depression? So I'm asking for two things. One is, why is it important? And two is, what are the kind of signs that you need to look out for? If you could sort of shed some light on this.
Okay. Thank you so much for inviting me to this panel for Prabha and organizers. I think when you hear to Latha and Lakshmi, it's quite obvious that you do see mental health problems in your consultation, and it's quite often that you see that. The challenge is, like Latha was just saying, how do you elicit the mental health problems? Because as obstetricians, you got a lot of other things to do, check for the physical health side of things, and there isn't much time to actually check for the mental health concerns. But going back to your question, Prabha, why is it important? It's important for many, many reasons. Firstly, you're talking about at the individual level, the sort of the health aspects of the mother, which play a big part in any sort of pregnancy and postpartum issues. Secondly, the issues that concern with mother and the infant bonding, which again has a huge implications for later sort of problems in children as they develop. And that itself is a sort of a big sort of area to focus on. So the whole attachment and bonding issues. And I think that is a big issue. The other thing is to think about the more economic costs to the society and the health system. I mean, there's a financial modeling done by the London School of Economics, a very important paper which came out in 2014, which talked about the cost of the mental health problems during pregnancy, amounting to 8.1 billion. And it was a paper by Sarah Parsonage, who was a financial economist. So, and in fact, that paper also highlighted that even in UK, where we call developing country, you need about 337 million pounds to get things back up to normal, to increase access to all these psychological and psychiatric resources for women who are pregnant and have postpartum problems. I think the last and the most important thing that I really want to highlight, like both our panelists mentioned before, is the actual suicide rate, is the risk and the suicide rate. And suicide rates is very high in pregnancy and postpartum, and it is so unrecognized. And obviously the way in which you kill yourself is different from in developed countries. But it is also highlighted that when suicide occurs in pregnancy, there are mainly violent methods that are used as well in quite a few publications. And probably in India, you'll see more of the burning with kerosene and all that, which you don't see much in the West. And in fact, there's a famous case of a psychiatry SPR who I used to work with. It's called the Daksha Emson case. And I'm not breaking any confidentiality by mentioning it, because that became a national inquiry in the UK. Daksha Emson was a senior registrar in psychiatry. I knew her actually before she died. When she was pregnant, I used to work with her. So it actually affected me quite significantly. Daksha was of Indian origin, heritage, but she married an Irish person who was a radiographer. And she had bipolar affective disorder. And of course, Daksha is unique because she was a psychiatrist, and she told her psychiatrist, I'm absolutely fine. I know the signs and symptoms of mental health problems. You don't need to worry about medication. I'm taking my medication. But none of the psychiatrists actually inquired, are you doing the right thing? So I think just to come back to the original question. So suicide is a very important reason. The other bit that you asked, Prabha, is how do you identify the signs and symptoms? And again, it is not easy, because you are focusing, there is a very obvious physical thing to focus on, which is, it's not just the pregnancy. There are a lot of physiological things with pregnancy which obstetricians focus on, the abdominal distension, the pain, the other sort of venous stasis, and all the other things that you focus on. There isn't much time, and you're also checking for whether the baby is growing or not, the ultrasounds and all. There isn't really much time to focus on. But and again, most of the patients don't spend a lot of time with the consultant obstetrician themselves, because at least in the UK, the consultant obstetrician do see them very infrequently, unless there is a very important, like preeclampsia or something happening. It is the midwives who actually see them more often. So I think we need to focus on both the levels of how, in a brief consultation, you pick up signs, and what the midwives do in terms of a longer consultation. What can they do? The obvious signs, like Latha and Lakshmi mentioned, are the ones that are hidden. So you might see some evidence of somebody being tearful, and you think actually you congratulate them for pregnancy, it's a happy event, and they actually look tearful. They talk about other things like medication they have not taken. They talk about feelings of being anxious. They talk about being generally worried about the baby. Am I a good mother? Focusing on those things. So when there are these opening sort of statements made, there's an opportunity to go deeper and explore whether they actually have the gamut of symptoms for anxiety or depression.
Thank you, Dr. Rangarao. I think you kind of highlighted many things. One is, of course, why is it important? Because of, we know that maternal depression contributes to poor development. It contributes to low birth weight and preterm delivery. It contributes to many long-term, and the whole area of DOHAD, of, developmental origins of health and disease, which is now such an upcoming, and the stress, prenatal stress, and its impact on many aspects of a person's health. And then you talked a lot about suicide. And I think it's very important for us to recognize that the confidential inquiries of maternal deaths in UK, Australia, New Zealand, Canada is actually highlighted that in at least in the countries, in the high income countries, suicide is the leading cause of maternal mortality, compared to all other causes. In India, that might not yet be true, but as we conquer other reasons for maternal mortality, we can expect that it'll come up. And in Kerala, where the confidential inquiries are being done with some seriousness, we find that suicide is a strong cause, and many of them have untreated mental health problems, which we can actually pick up and start treating. I'm going to ask Veena a little bit about anxiety, because we heard Lakshmi saying, more than even depression, it's anxiety. We also know that anxiety is actually useful in pregnancy and postpartum. I mean, it's almost like an evolutionary thing that you should be anxious. You should be anxious about your health. You should be anxious about the fetus. And it's actually good because you protect yourself. So when do we decide that anxiety is pathological? And how does anxiety manifest? Veena, if you could just sort of focus on that, both in pregnancy and in the postnatal period.
Sure. Thank you for that question, Dr. Prabha. Like all of you have pointed out, anxiety is a common presentation both during pregnancy as well as in the postpartum period. So typically, if I were to crudely categorize the women that I see into two groups, there is one group of women who have trait anxiety. So trait anxiety is, essentially that these women are temperamentally predisposed to anxiety, which can potentially worsen either during pregnancy or during the perinatal period. There's a second group of women who probably have anxiety onset in the perinatal period itself. So in both these groups of women, we see that the component of worry is quite significant. Like you said, a lot of anxiety can in fact be protective. So at smaller, level of intensity, it can actually be useful because they, find out what are right things to do to protect themselves, right things to do to protect their fetus. So they're interested, they read up, they ask you questions. All of that is quite fine, especially in first-time moms. They're quite likely to have a lot of questions about the process of pregnancy itself, as well as the perinatal period or the period post the birth of the child. In a lot of women, anxiety manifests also as having very increased amount of fear. They're not able to function. They feel very restless. They're, pretty much expressing an inability to rest, to relax. Nothing that they do is able to sort of soothe them or, even sort of help them in terms of regulating their mood. They seek a lot of reassurance from their immediate family members, healthcare providers, obstetricians. And sometimes, even though you do your best to reassure them in the time that you have, they're not easily convinced. So they keep coming back with pretty much the same kind of questions. They read up excessively on the net, which sometimes is not useful. So these are some of the manifestations of anxiety at one end of the spectrum as well as on the opposite end of the spectrum. And it can have quite a significant impact both on the mother who experiences this anxiety, obviously the fetus or the child, as well as the family.
Dr. Veena, I think, it's very important, like we said, to kind of differentiate between what is normal anxiety, what is pathological anxiety. Dr. Latha and Dr. Lakshmi mentioned about conditions like tocophobia, which is like real intense fear of labor, which can be a manifestation of anxiety. We've also found, mothers having obsessions about, constantly checking, and OCD can actually surface sometimes during the postnatal period, particularly, and can be quite difficult to handle. I'm going to now ask both Latha and Lakshmi, and Latha can talk first, is about, so we all know why it is important, that it is present, that, the prevalence ranges from 10% to 20%, depending on which group of women you're talking to. So if we are looking at, women in a routine obstetric setup, around 10% is the rate of depression and anxiety in pregnancy, increases in the postpartum period. And but we all know that the obstetric care providers, be it midwives, nurses, obstetricians, face quite a few challenges when it comes to referral, because women are not terribly keen to go and see a mental health professional. So I'm going to ask Latha first about what are the kind of challenges, but how have you been able to overcome these challenges? And, what are the things that people can use, and what's your advice to people about how you've been able to figure out? I mean, I think most women whom you pick up and refer actually come to us and reach us. So what are the tricks that you have in you that you sort of are able to do that? Could you highlight a little bit?
I think, as I said before, I think awareness about the mental health issues amongst the obstetric population is very, very important. So we educate our nurses, juniors, and also colleagues. We do have these sessions where we sort of talk about a few cases that we would have seen on a week-to-week basis where mental health issue was missed or recognized or whatever. So I think every visit we do ask women how are they feeling about their pregnancy, are they happy, do they have any problems, etc. So I think these are very important questions that we have to make time and ask them. And finding subtle signs is very, very important. That has been discussed. And also we educate the family if they are at risk. If we feel that they are at risk, for example, if there is acute stress, like Lakshmi mentioned, divorce during pregnancy, it's not uncommon to see divorces during pregnancy. And if they have had poor obstetric outcomes, or if they have had previous mental health issues for which they have had treatment or stopped or whatever. So we have tried to sort of tag them. And we do have a high risk column where we mentioned these and also how they need to be followed up. And also most of them, we do refer not only to the perinatal mental health team of NIMHANS, and also we do have counselors whom we refer them to. And the counselors usually, we do say, look, go and see the counselor. If you don't want to see the mental health team, at least go and see the counselors and then let them take it up. And also it is very, very important that we have a rapport and say, look, it is your baby, which is very, very important. If you are not mentally healthy, your baby can also have developmental issues, etc., etc. That impresses the women quite a bit. And I feel if we have a care pathway, we have formed a care pathway that is where, when to refer, whom to refer, and where to refer. All of our members in the team and also the nurses know when, and also nurses sometimes come back and say, look, she was crying, she was quite tearful, she is not very comfortable with her mother coming into the consultation room, or she was having a fight with the husband in the lounge and things like that. So even the nurses have to be made aware of, and how do we refer them is also very important. And also whether we can have a perinatal mental health combined clinic is one of the things that is very, very important, because the mental health issues, I would say up to almost 20%, if you took anxiety into consideration, almost 20% of women, 1 in 5 women have this problem. So one of them is perinatal mental health combined clinics, or mother and baby unit, where they feel that we are not just referring them to a psychiatrist, but we are referring them to a team of doctors who are very concerned about their pregnancy and also want to give them the best, to get the best with their baby. And also we talk about long-term mental health issues, who can talk about long-term mental health issues if the mother has been mentally unwell, etc., etc. So on the whole, we try to counsel them regarding the importance of mental health issues and how it can affect the progeny if they were not taken care of, and where to go and see these doctors or counselors, and we ring them up so that the woman is not lost in between us. And also we keep 24/7 line open for them to contact. That's the emergency number that we provide not only for mental health, but it is obstetric emergency line. But all of us would be aware of mental health issues, and then we refer them onto the mental health team as and when required. So, and also we are, I would say it's a privilege to work with NIMHANS team, who have formed a perinatal clinic outside NIMHANS in a residential area. So people feel quite comfortable to go there and discuss their problems. I think it's very important that we have a mother and child unit separate or away from the routine mental health hospital or psychiatric consultation chambers. So,
thanks, Latha. You sort of flagged so many issues, but I think one of the important things which struck me was, not just the one obstetrician who gets sensitized, but sensitizes the whole team about mental health issues, so that wherever she is in the journey, with the midwife, with the nurse, with the obstetrician, somebody picks it up and sort of talks about it. So I think it's extremely important for the whole team and for the whole system to be sensitive to mental health issues, and to also make the referrals in a very sensitive manner. And the relationship between the obstetric team and the mental health team, again, is extremely important, so that the mental health team also gives you feedback about what's going on. So there's a dialogue which happens, so that the mother doesn't feel that she's been palmed off to somebody, but sort of recognizes that we are talking, like you said, about a care pathway. And I know, and I'll come to Dr. Ranga, where there's some wonderful practices done in the UK about care planning right in pregnancy, which happens so that you can prevent a postpartum relapse, and we'll come to that. But I'm going to ask Lakshmi, what are the kind of barriers that you have faced in ensuring that mental health problems are addressed in obstetric care?
Dr. Prabha, I think I would like to put it into two categories broadly. I think in the first category is the group of women whom we have actually come to some conclusion, either a provisional or a definite diagnosis of a condition that is going to require subsequent perinatal mental health follow-up. And in them, the barriers that we face is the non-compliance, because unlike Dr. Latha, where there is a luxury of a good system, here the referral pathway is to their own individual doctors with whom they've already had care. And some of them quote logistic reasons and don't go. Some of them come back and say the doctor did not give me a letter. So, there are still things that need to be streamlined, even in people for whom there is recognition, there is family support, and a established care pathway. So I think eyes and ears open all the time is the only thing that we can do in these situations, so that the tick list helps. That have you seen your doctor? Have you spoken to them? For us to get feedback. And that is for most of these patients on an individual basis rather than a streamlined system. So I think that is the challenge. Whereas the second category is where we are struggling to come to a diagnosis, but we have a feeling something may not be right. And in that particular group, what we find as a big challenge is, even when we think we have used our communication skills in the best possible manner, we have addressed confidentiality, the minute we start using the word of counselor or psychiatrist or psychologist, I really don't understand why, but immediately the answer is a shaking of the head and no, because there seems to be so much of a stigma in the individual's mind itself. So I think trying to destigmatize the individual concerned itself is the biggest barrier that we face. And then obviously is going into who the referral pathway is. Within our system, we have a psychologist who's in-house. So that tends to be a very useful referral pathway. But even between two rooms and two buildings, sometimes patients find new excuses to say, I had a phone call from home, I had to go away. But these are the same women who will wait for 4 hours for an ultrasound scan, or, for the whole day if their concerned doctor has to come. So there is a lot that we still need to do to streamline the system, is what we have understood. And I think Dr. Latha's point is very valid, because the nurse coming and telling us that she was upset in the waiting room is quite often the first important clue we get to diagnose the undiagnosed. So I feel the way we can overcome is by team working. We surely have a lot of friends in different specialities. And I think for us to build up networks, and I think the UK model is very good when it comes to these sort of networking. And that's what is happening in Bangalore. And I think that is definitely the need of the hour.
Thanks, Lakshmi. I think one of the things that both Latha and Lakshmi have highlighted is one is the importance of easing the whole journey, to make it seamless in some way, to smoothen the path to reaching a mental health professional, and, joint clinics or having clinics in areas which are less stigmatizing, somehow getting mental health to be more easily accepted is an important aspect. I also think that, one of the things that that has happened in the UK is that it's part of every obstetric meeting. Any antenatal setup actually has routine screening, which is happening in many of the countries. And there are, of course, advantages and disadvantages of screening and different screening methods and cutoffs and all the challenges that we have with tools. But if we can develop some very simple methods, like maybe using something like the Woolies questionnaires, which are just 2 questions and are easily picked up, rather than sort of, having tick boxes, which in India at least, and many other countries in Asia, I know women are not terribly happy about, questionnaires. They like a more conversational kind of style. And despite the fact that the obstetrician is really busy doing many other things, to develop an easy method of detecting mental health conditions may be important. I'm going to go to Dr. Ranga and ask him a little bit about the UK model, because I know that, over the years, the UK model has really evolved. At a time when there were hardly any mother-baby units, now there are so many mother-baby units. The government has invested heavily, not just in severe mental illness, but also in integrating mental health into routine antenatal care. And we have so much to learn from you, and we have many advocates in the UK. We have patient advocates, we have professional advocates who talk about perinatal mental health. So could you sort of give us a sense of how did this happen? How did perinatal mental health become one of the top priorities for government, for systems? And what can India and other low middle income countries, other Asian countries learn from the UK?
Thank you, Prabha. Yes, thank you. In UK, I think there's been a tremendous explosion of perinatal sort of services in the last sort of 5-6 years. I mean, there was a lot of perinatal before that, but primarily things have expanded because of the government policies. So we have what is called as a 5-year plan, and all these things work when you have leaders who champion the cause. Like, for example, Trudy is a big champion nationally. She's the chair of the faculty. And there were enough representations at a highest policy level. For example, in UK, the person who generally decides on the purse strings or other influences the ministers is called the National Clinical Director for Mental Health. And we had a wonderful, just a frontline clinician called Geraldine Strathtree, who was a NCD for mental health. So in her time, clearly the issues that she saw as important really got higher funding. And that is the Liaison Psychiatry expansion and the Perinatal Psychiatry expansion. So I won't go into Liaison expansion, but the Perinatal expansion happened as a consequence of that. So what we have seen is new investment in perinatal in the last 5 years. And more so in the last 3 years, the new investment has been with regard to, firstly, creating inpatient mother and baby units. So we expanded the mother and baby units. In fact, like you said, Prabha, we were the first unit in the country, the inpatient unit I work on. But even within our area, we have got one other mother and baby unit. So they literally took the map of the country and said that areas don't have access. You need those. It doesn't matter. It's not linked to institutions, but linked to geography as to where, for example, in spite of everything, Northern Ireland, I did a piece of work in Northern Ireland looking at the acute bed capacity there. And I was completely shocked that there was not a mother and baby unit in Northern Ireland. It's a dual state of United Kingdom. There are plans to open one now. So the first one was the expansion of the mother and baby unit. The second one was expansion of what we call the community perinatal teams. That has been a hugely important imperative. So in every area, so for example, in our trust, there's only one mother and baby unit, but in each borough, there's a fully formed community perinatal team. The community perinatal teams have a consultant psychiatrist, community psychiatric nurses who are in perinatal mental health, psychologists, occupation therapists, and we also have a new breed in UK, which probably may not exist in India, as Chandra corrected, called nursery nurses, who play an important part in the sort of basic mother-baby interactions. Every team has some of these professionals. It's a fully formed team. The other thing that happens in UK is there's a lot of emphasis on liaison psychiatry, as I mentioned. It has really improved in the last 20 years, the liaison psychiatry. So there's a component called the perinatal liaison, which, like you were describing, Latha and Lakshmi, that is the equivalent of having joint clinics. So you actually link in with the obstetricians and midwives in general hospital to intervene very early when there are very early symptoms. You can see them in a joint clinic, but they're actually based in the general hospital. So like Prabha mentioned, the stigma is not there if you're seen in the general hospital itself with the midwife or something. So, and then the other thing I need to mention is, in UK, a very important thing is if there's a mother who is a high risk, who's at high risk, as we call it, high risk as in high risk of developing a major mental illness during pregnancy, there's what is called as a pre-birth planning meeting. And that happens systematically in all hospitals. So a pre-birth planning meeting takes place between 30 to 32 weeks. All professionals who are involved in the care, obstetrician, the general practitioner, psychiatry, midwife, health visitors, everyone is in. Social services, another big thing in UK. They're in to talk about a very detailed plan as to what support the mother will receive, what are the risk indicators, what will we do in the event of a risk, where is she going to have the baby, immediately after the baby in the general hospital, if she needs a mother and baby unit, which MBU will she go into. All those details are actually worked through, and a pre-birth plan is written by 33rd week of pregnancy, and that is circulated to everyone, so nobody's in any doubt. Having said that, we still are not a foolproof system. This is how the system is set up, but in reality, we still play catch up a number of times. I don't want to get the impression that it's an all singing, all dancing system. Things are still evolving. There are a lot of areas that don't have community perinatal team, a lot of areas where liaison psychiatry is still developing. But this happens in about 60% or 60-70% of the time.
Thanks, Dr. Ranga. I think you highlighted the importance of several things. One is the importance of leadership, the importance of political, involvement, and government involvement in improving services, the advantage of not just having hospital-based mental health teams, but also looking at community-based teams, which can kind of, continue the work. And many women would like to be looked after at home. And I think a very important thing, which I learned as well in the UK, was the whole planning, the pre-birth planning, which is such an important aspect that you don't, when there's a small baby, you're just not struggling. Where is this woman going to? What's going to happen to her? And everybody in the team knows what is going to happen, including the mother and the partner. And, so I think that's a model to aspire for, and, we need to work towards it. We probably have some a few 10 minutes or so left. And I'm going to ask Dr. Veena a little bit about the role of psychological interventions and what are the kind of situations where a clinical psychologist can actually intervene. What kind of therapies are available, and when should the midwives or the obstetricians refer to a clinical psychologist? Could you sort of give a little bit about that?
Sure. So I think in perinatal practice, psychological interventions have become very important. Like we've discussed, more important in the case of common presentations like depression, anxiety, stress. Sometimes it need not even be a clinically diagnosable kind of an anxiety disorder or a depressive disorder. A lot of women present with stress of subclinical threshold or severity. We do have very sophisticated psychological therapies for women with personality disorders. We tend to see quite a lot of women with these personality disorders in ENHANCE, for instance, whereas in the community clinic, we probably see, minor presentations of distress. So typically, we do have, evidence-based psychological therapies like cognitive behavior therapy, interpersonal psychotherapy that are offered. Like Dr. Prabha very rightly mentioned, the dosage of psychological interventions and therapies may differ. So obviously not all women need to come to tertiary care facilities or to very specialists like clinical psychologists to receive psychotherapy. Women presenting with milder levels of psychiatric problems can benefit with various people offering psychological intervention. So NIMHANS is training quite a lot of people who are postgraduates in psychology to be able to bridge this demand-supply gap that is there in the field of mental health, and also be able to deliver some simple interventions, which is like first line of psychological interventions to people who need them in the community. So the same principle in a stepped care fashion would apply to the perinatal, women seeking help. Very specialized interventions will be required, like Dr. Prabha mentioned earlier, for women with OCD, women presenting with post-traumatic stress disorder, either following birth of a child or probably even in the pregnancy period. We do see a lot of women presenting with trauma across the lifespan, and some of this becomes very relevant in the perinatal period. So this is an instance where, again, specialized trauma-focused interventions and trauma-informed care becomes very important. And of course, for women presenting with long-standing personality issues like borderline personality disorder, definitely more sophisticated psychotherapies and specialists will be definitely more relevant for them.
I think you kind of highlighted the various kinds of therapies, and I think emphasized that not everybody needs a clinical psychology referral, but there are certain things which counselors can do. I think everybody in the system should probably know when they can do something and when they should refer on, and the limits and boundaries of that engagement. And I think that helps. But having said that, I think psychological interventions have a great role, and I think we need to sometimes allay anxieties of mums, because many mums, particularly in the pregnant period, do not want to take medication. And so the moment you refer them to a mental health setup, the first fear is, oh, I will be given medication. So maybe to kind of emphasize how there are many other methods by which women can be helped. And, if they have psychological interventions, then maybe the need for a higher dose of medication can be mitigated. The mild to moderate conditions can be managed with psychological intervention. So I think people need to know that. I'm going to ask Latha a little bit about two things. One is this whole area of obstetric violence, which is gaining a lot of importance, which, the fact that during labor, during the whole course of childbirth, particularly, many women are not treated respectfully. I know the government of India, for example, has this whole program of respectful maternity care, but your sort of, your shout out to all the midwives and nurses who are listening about the importance. It's such an important thing, because like Dr. Veena said, that many times women who've gone through previous trauma, if they go through obstetric violence, the trauma just gets heightened and then manifests as PTSD. So one is the relevance of that. The second question is, at a time when we are talking a lot about integrative medicine, the role of yoga in pregnancy and in the postpartum period. So these two I would really like you to address.
Yeah, thank you, Prabha. Obstetric violence, I think it is seen not only in the rural areas, but also in the cities, unfortunately. So the dignity of care, respectful care, has to be maintained throughout pregnancy and through labor and even postpartum. Especially during labor, when that's the height of stress that the woman will be going through. And I think it's very important that we don't add on stress. As doctors as well as caregivers, they should not be adding on stress. In fact, they should be giving a lot of solace. Dignity of care, unfortunately, it's unfortunately suboptimal in many, many places, starting from the birthing couch to the other obstetric practices like prepping the perineum, etc., etc. It's all done with such casualness. It is very unfortunate for the woman, and it can be quite traumatic. And shouting at the woman who is laboring, not being supportive during labor, and also just having a very casual attitude even when the woman needs the caregiver's support. It's all very difficult to accept. And also I have seen violence even from the family members, or even from husbands, during labor, which is very, very unfortunate. So I think it's very important that we train our staff and also make them put themselves in their shoes when, if they were treated like that, how would they feel? That sort of a, we do have these mock drills and try to emphasize what do they call the place, the scenarios where we teach, which is a very ideal method to sort of deal with the laboring women and things like that. So that's how we train. It's almost become a drill in the unit. So obstetric, and also I think government should also take it up very seriously. Staff who have been, rude to the women, I think they should have some method of critically appraising them and things like that, which we don't see from the government, and also from various institutions. We are not seeing very effective interventions regarding that. That is about obstetric violence, and which could traumatize, which could cause more postpartum mental health issues and things like that. And also, not only obstetric care, Prabha, it is treating the baby very casually is also another thing which needs to be sort of looked at. The baby is not even sort of properly wrapped, not put to the breast, and it's just kept separately from the mother for quite some time and things like that. All those have to be looked into if we are talking about obstetric, if I may say, violence, or obstetric, intrapartum obstetric respectful care. The next thing is about the integrative approach. Stress has become such a problem during pregnancy, which is going to affect the quality of progeny that the mother is going to produce. Lot of evidence about intrauterine atmosphere and long-term problems with the progeny, that is both at mental and physical level, is more than established now scientifically. So I think integrative approach, especially yoga, which can reduce, which has shown scientifically to reduce stress, I think should be practiced by every woman. In many countries, yoga has been promoted, propagated, especially for pregnancy, to get quality progeny. That's how they put it. And I think we should make our mothers very much aware that the mental and physical programming of a baby in the intrauterine period is of utmost importance to get the best as an individual who has good mental and physical health. So we are able to sort of convince the mothers, if they're under a lot of stress and also scoring high on stress, to do yoga, to pursue their hobbies, and also to have some other alternative systems of medicine also, like Ayurveda, which can reduce the requirement of modern medications, which might have more side effects, but a lot of research has to come up in that field. But yoga, we have used it as a tool and published quite a few papers, not unfortunately in the area of mental health issues and pregnancy. Papers are yet to come out. We are in the process of the studies. So that's what I would like to say. We should have an integrated approach to these women who are going through so much of stress. And stress added on to anything physiological like pregnancy can become, the condition can become pathological. So if we can minus the stress, it will go a long way in keeping the health of these women.
Thanks, Latha, for addressing those two very, very important areas. I'm going to ask Lakshmi for about two things. One is, what do you think is the importance of training of obstetric care providers? I'm not just saying obstetricians, but midwives, nurses in perinatal mental health. And what is the role of partners and spouses?
Dr. Prabha, I'm wondering if you're doing mind reading, because those were the points I'd written down and kept as Dr. Latha was talking.
That's what I do for a living,
And you're doing it very well online also. I think training definitely is the area that we have to make our start with, because a lot of us have just learned from our peers and we just continue practice. And though we talk about CME, CPD and all, I think certain habits, when they come, they never go. And I have realized that looking at our postdoctoral fellows also, where, sometimes you are needing to tell them the basics again. But as a trainer, it is your responsibility to ensure that simple fundamentals of confidentiality, respecting a patient, treating them with dignity is never overlooked, even when you're observing it casually being done to somebody else. So I think training definitely is very important. And during the training, we talk so much about partogram and assessing, but I think the soft skills are really not at all emphasized. I've had a forum when I was discussing about hand hygiene, and somebody spoke to me later to say, why as a consultant coming from UK would you talk about hand hygiene? I think there is still that stigma of certain things you don't need to talk about, it'll happen, but they actually are not happening. So I think we should, every one of us as obstetricians, owe it to the pregnant ladies to not watch them go through anything that is not respectful. I think that is to be inculcated in the training program, and that includes the nurses, and that includes when you go to other wards to see patients also where, they are not being, covered properly. So I think each time you keep telling, the message will go around. So I think training, and in the training aspect, to actually include perinatal mental health as a curriculum, I think that's the best way that they will notice it as an eye-opener, and they will know that you can actually improve low birth weight, you can actually improve the developmental outcome of children, which is a huge problem in our society. I think that will sell the fact of perinatal mental health is so important. So I think training definitely is important. I feel in the training aspect, we can also train our patients also, because a lot of times if you tell the patient, these are the things to expect, labor will be like this, antenatal classes, and get the person who's going to be with them through the process and educate them also. That is actually a very powerful tool. And I've seen many a times the families itself ensuring dignity is happening and respectful care is happening in their own very, very subtle way without making it confrontation. So I think empowering the women also with the knowledge is very, very important. So I think training definitely is a big, big star over there, which we have to now highlight more. When it comes to support and family, I think one thing I've realized is that there is somebody in the family who's actually moving the cards. It may not be the husband, it may not be the father-in-law, it may not be the mother-in-law, but somebody has the maximum influence on that patient. I think for us to recognize that is very important when we are providing antenatal care, because how much ever we convince the patient or the husband, unless we can convince the person who's taking the decisions, we can actually not be successful in delivering the information. So I think talking to the patient alone as many times as possible in the pregnancy so that we understand to know how to communicate things effectively is also a very important.
Thank you very much. And I think, as you say that, I also know that there's been a lot of work now which is coming up on the whole role of the father, and of course on paternal depression as well, and how the father needs to be a very important part of that whole journey of birth and child development, which I think at least in our country and many other Asian countries has not been recognized as much as it should, and probably should become part and parcel of our care methods also. I know we're running out of time, so I'm going to ask each one of you to give a take-home message in the area of perinatal mental health, and I want to start with Dr. Ranga Rao. What would you like people to take back from this panel in one sentence?
early identification of problems.
Okay. Latha, you have to unmute yourself.
Forming a proper care pathway for referrals. Yeah. And of course, making sure that we identify the cases.
Okay. Dr.
Training
Veena.
us.
Veena, please unmute yourself.
I would like to say that mental health problems during pregnancy and postpartum period are definitely treatable, and it's important to seek help at the right time.
Thank you. And Dr. Lakshmi, for your final takeaway.
Destigmatization, I think, is the way forward, because even when we know, stigma stops us from doing what can be done. So I think knowledge and destigmatization both are as equally.
So I think that, we've had a very wonderful and animated discussion. And I think ending in a very optimistic note. We all know that one of the hallmarks of resilience, which is being talked about a lot these days, is optimism. And I can hear optimism in everybody's voices, that despite all the problems we have, despite all the challenges we have, here are, 4 clinicians who have actually taken it, in their whole, it's like a challenge. It's like their life's mission to ensure that women who are pregnant and postpartum get the kind of mental health care that they should. They've all done it in their own ways, and you've listened to all of them about, what can be done and what is possible. So we're hoping that this panel will inspire all of you to train yourself in perinatal mental health, to be, easily identify women. You heard from Dr. Veena that these are treatable conditions, so there's no reason to feel bad about it. The role of stigma and how we need to remove it, and finally forming teams and the importance of good care pathways. So on that note, I'd like to thank the organizers for inviting me to moderate this very exciting discussion, and we are hoping to answer some of your questions in the Q&A time that we have. Thank you very much. Thanks to all the panelists.
Thank you.
Thank you.